Good afternoon, everyone. I'm Dr. Erica Trappel, and on behalf of the Prevention Research Center for Healthy Neighborhoods, I'd like to welcome you to our December seminar, which is our last seminar for the calendar year 2023. And we are wrapping up with Dr. Marcia Tan, who will be presenting today, Adapting a Tobacco Cessation Training Curriculum to Promote Intervention Delivery Among Community Health Workers. But before I introduce Dr. Tan, let me walk you through our usual hello. So if you are not connected with us, please do connect with us. You can catch us on our website at prchn.org, and at least for the time being on what was formerly known as Twitter at prchn, Facebook, LinkedIn, or YouTube. We do record and post all of our seminars on our YouTube channel, so please feel free to visit our YouTube channel for this recording, which will show up in the next week or so, and our past seminars. We always like to highlight our next seminar speaker, so we hope that you will join us for our next seminar on Wednesday, January 10th at noon, where we will be featuring Dr. Danielle Smith from Roswell Park, whose research is in the area of cannabis and nicotine co-use and public health policy. We'll have a title for you shortly, but please do consider registering and joining us next month for this really interesting and timely talk, especially here in the state of Ohio. Before we get started, just a few reminders in case some of you are new to our seminar today. We're going to use the chat feature for our question and answer, but we're also going to ask you to please add your name and organization in the chat today to introduce yourself to others who are joining. We do miss our in-person format, but have really enjoyed being able to engage with others across the campus, across the state, across the country who are able to join us. So please do introduce yourself in the chat. We're going to let Dr. Tan give her presentation, and then we will be more than happy to take questions after her presentation. We can use the chat feature to do question and answer, and we're happy to have you raise your hand and take yourself off of mute to directly engage with Dr. Tan and ask your questions. And now, with no further ado, I am very excited to introduce Dr. Tan. Dr. Tan is an assistant professor in the Department of Public Health Sciences at the University of Chicago. She's a licensed clinical health psychologist with a background in epidemiology, and her work focuses on health disparities and modifiable cancer risk factors, including tobacco use and weight gain, and cancer prevention among underserved populations. Her specific research interests are first in examining biopsychosocial and behavioral factors that contribute to disparities in cancer, and second, conducting community-based health behavior interventions to reduce risk factors among underserved populations. She is in good company with those of us here at the PRC, and we're very happy to host her. She received her PhD in clinical psychology from the University of Miami, an MPH from the Rollins School of Public Health at Emory, and a bachelor's in psychology from the University of Alabama, Tuscaloosa. She completed her postdoctoral training at Northwestern University as an NCIT 32 fellow in cancer prevention and control. And so without further ado, I am very excited to hand this off to Dr. Tan. And we'll ask her to share her screen with us now so that we can enjoy her presentation on, on adapting a tobacco cessation training curriculum to promote intervention delivery among community health workers. Take it away, Dr. Tan.
All right. Thank you very much. Everybody see my screen okay? Perfect. All right. Well, thank you for the introduction. I'm very happy to be here. I was mentioning that I feel like based on the website, you all are my people. So I'm happy to present to you my project. And again, I'm going to be walking through my process of adapting tobacco cessation curriculum, specifically for community health workers. And I'll present some pilot results very briefly at the end. Oh, and I have no disclosures and some of the funding sources over this project, but that has been going on since 2017. So it's about 6 years in the making now. And you already heard about my background, but I just like to put this slide up here just to say that, you know, as a clinically trained psychologist, I really think a lot about the individual perspective within public health and these public health programmings and campaigns that we have. And that's kind of my framework and how I approach my research. And before I get started, I like to put this on all of my slides just to show the complexity of health disparities in this country, and just knowing that, you know, a lot of us were trained, I think, in individual boxes and individual fields, but really to think about cutting across multiple levels of influence and also domains of influence when we're thinking about addressing health disparities in this country. And this with the NIMHD, this framework comes from the National Institutes of Minority Health and Health Disparities. And this is kind of the suggested way we should kind of think about this as far as research. And I've been operating a lot in this individual level column over here, and I'm really trying to move and think about more community engagement and community level when thinking about addressing health disparities. And as mentioned, I kind of have two areas of research, just to give a little introduction about myself. The first is a more traditional epidemiologic research, where I call it like exploration, where we're still trying to understand the connection and interaction between psychosocial experiences and behavioral, and how that contributes to and sustains disparities that we see. And then the second one is really kind of getting out there in the community and intervening on these things. And that's what I'll be talking about today. As far as you know, training the community health worker workforce to really address and think about getting access to treatment out to populations who need it. All right, so just as a quick background, I probably don't have to say this, but just as a reminder, you know, we've been doing well, you know, with reducing rates of overall commercial tobacco use in the US. You know, overall, since the 60s, the rates have been declining steadily, you know, but we know that that's not for everyone. And we still have subgroups of people who smoke at higher rates and disproportionately smoke at higher rates. And their rates have been, you know, kind of sustained over time. And this is what I'm really interested in thinking about, you know, since we've been, I think, tobacco use and the decline in tobacco use has been one of the biggest public health wins over time. We still haven't finished the work, and I think we've kind of like moved on as a public health field, but there's still these populations that need help, and that's where, you know, my research area, my research focus is. And then one of the key problems that I'm interested in addressing with this project, particularly and in general, is the fact that, you know, the way that we've designed tobacco cessation interventions have largely been within, you know, clinical spaces, or, you know, thinking about brief interventions in the 5A's models. Those were developed for clinicians, and they're great and they're effective. We've shown that they are very effective, you know, but there's still a good proportion of people who have these disproportionate rates of smoking that aren't being seen in healthcare system or healthcare settings, and they, you know, don't have primary care physicians, or not really receiving the advice to quit. Or if they are engaging with the healthcare system, there are more acute issues that are at play, like chronic conditions and other things like that. And so, you know, my question is, how do we reach this population? So I've been working with community health workers since 2017, when I actually was working with the American Lung Association, where the project actually started because there was a tobacco control specialist at the American Lung Association who had community health workers, or CHWs, I'll shorten, that complained that their freedom from smoking training was just inaccessible to them because it was too expensive and too long. And so they were like, can you give something to us? Is there anything available that we can have, that we can use? And so community health workers are, you know, broadly a workforce that kind of serve as the bridge between the healthcare community, or the healthcare setting, and the community members. And so I like this like figure because it kind of shows like their connection between, and that they really are connectors. They're really designed to connect to services. And this is the official definition from the American Public Health Association website. And they're really classified as the frontline public health workers that are like in the field, seeing patients, seeing community members wherever they are, really to facilitate this access to services to improve overall health. And they do a lot of activities, and they wear many hats, as I say. And it could include, you know, patient advocacy, cultural mediation, but largely they do a lot of assisting with chronic disease management, I think, in the US. And CHWs are found globally. They've been in existence for decades across the globe, but in the US, primarily they've been working in the area of chronic disease management. So a lot of diabetes management programs, or asthma programs, and things like that. And they do a lot of health education as well. But they because of the way that they work, they have they build trust with their patients, and oftentimes they come from the communities that they are serving as well. But so the role of the community health worker as an official healthcare workforce was recognized officially as part of the ACA back in 2010. But the issue is that the recognition varies by state. And so, maybe a little bit more than half of states have an official certification to become a community health worker, but some of them don't. So Ohio, for instance, has a process for CHW certification, which is excellent. Illinois does not. So we still are working on that. We have an advisory board that has been meeting, to kind of come up with what would a certification look like. But I think, inherently some of the difficulty is that because they are so variable in how they and the service they provide or how they, deliver services, it's kind of, I think it's still it's still like something to think about. What is a requirement? What should be a standardization of being a community health worker? I'll talk a little bit more about the community health worker role. So for our project particularly, there's several tobacco cessation trainings that exist to help people quit smoking. There's several trainings on teaching people how to provide brief advice or brief counseling. And the rationale for this project is that not necessarily that we wanted to create a protocol for tobacco cessation to recruit and teach CHWs to do. We were like, well, if CHWs are already out in the community, they already have face-to-face time with individuals that are using tobacco. How do we equip them with the knowledge and tools they need to give brief advice and help connect them to further services? And so our idea was that, well, we know that what exists right now, like we we're working with the Lung Association, we've gotten feedback that the way that because of the way that they're either certified or not certified, there's limitations of what they can what kind of training they can get, how much they can pay for trainings, like what their employer is going to pay for. If they're not getting access to those training, how do we modify what exists right now to be accessible for CHWs to get and also relevant for the people that they see? With our long-term goal to really develop adapt something that's scalable and accessible for community health workers to help use with their patients who use tobacco. This is like a nice little graphic that one of my teammates created to kind of the idea of that CHWs are often working with underserved populations. They're often working with people who carry the burden of tobacco use and other chronic conditions. And so, many of our interventions, a standard intervention like this is Mary, meet Mary. They might go to the hospital, they might get advice, they might actually go to an 8-week session or go to counseling or go to groups. But when they come back, they're coming back to this environment that's, full of recurrent, stressors and traumas and things like that. And they just need like extra support. The community health worker model of care is one that they are seeing the patients in their environment. So whether that's at home or at church or their grandchild's school or the hospital, because they have this ongoing relationship. Again, how do we build capacity in this workforce to do what they're doing and to kind of enhance the skills in the realm of tobacco cessation? So this is like the overview of our project, and I'm going to go through like each of these steps. But we want to start off with a needs assessment first, because obviously we've been doing tobacco cessation work forever, and I really want to know, like, is it useful to adapt something? Is it just a matter of we need to like just connect them to different tobacco cessation training curriculums and things like that? And so we start off with a survey that we created. It was about a 45-question needs assessment survey to see CHW's current tobacco cessation services, if they're asking about tobacco, if they're advising people to quit, their knowledge about tobacco use, and then their preferences for like what a tobacco cessation training would look like. And this is when I first developed the survey, it was back in like 2017. I developed this nice survey with like all of my Likert type scales and like everything like that. And I did a little cognitive interviewing with 2 community health workers to review it and make sure it was appropriate for them. And about halfway through the survey, one of the CHWs was like, I can't finish this. It doesn't make any sense to me. And I was just like, so can you talk to me about like what's wrong? And so, basically it was like the way that I approach this as a clinician, as a psychologist, like I'm used to having like maybe a 50-minute session with the patient, or even doing a consult, doing screener questions and doing things a certain way. And they were like, that is not how we interact with patients. It's not like prescribed like that. We don't come in with an agenda. We might have an agenda, but we have to respond to their needs. So we had to rewrite the entire survey that with answer options that were specific to the CHW experience. And then we distribute the survey to CHWs and also lung health professionals like respiratory therapists and medical assistants. We also have translated the survey into Spanish. That was one of my students' projects to also see if there were different needs for Spanish-speaking populations who served Latino populations versus English-speaking ones. We followed up the survey with a focus group of 6 community health workers that worked in a community-based organization on the west side of Chicago here. So the focus group really followed up with, getting more information as a follow-up to the survey, get more information about the interactions with their patients, really, and kind of like what is their workflow like, and how do they really engage with patients? And some examples of the questions that we asked the focus group. And what we found is that, it's true, CHWs are working with these high-risk groups. So not just people who smoke cigarettes or use tobacco, but people with mental health disorders, substance disorders, chronic illnesses, those experiencing homelessness, and also a range of racial and ethnic groups and sexual gender minorities. And then we found that from the survey that although CHWs asked about tobacco use, very few were confident in addressing it or doing something about it. And overall, particularly I think one of the more important things that we learned here was that the tobacco knowledge was low. So we designed a 10-question tobacco knowledge questionnaire that talks about the kind of 3-section of tobacco use in the U.S., tobacco cessation strategies, and then also just general questions about the nicotine addiction. And then we found that there was a gap in knowledge here about tobacco use for the sample of CHWs. And then what we found from the focus group was that, these are just bubbles to represent the themes that I'm about to present, is that there's a great flexibility in the CHW care model, where there's a lot of variability in where they saw patients, and also the number of sessions they gave. So they really talked a lot about the fact that they are very responsive as a workforce. So even though they might have a protocol to do diabetes care management or like an asthma protocol, when they get to a patient's home, there might be other things they have to address, because primarily the workforce is really designed to address directly those social determinants of health and provide support around some of those basic needs and social needs of the patient. And so like one person gave me an example of the fact that they spent an hour and a half at home with one of their clients or community members working on trying to fix their thermostat, because they thought that the thermostat was related to like their child's like asthma attack, and like so they just spent an hour and a half trying to troubleshoot the thermostat or figure out who to call to fix it. And so that was the visit, right? And so she had to follow up then to like talk more about the health related things that she planned on, but she had to really focus on that in that moment. So here's a few quotes. We met them wherever they felt comfortable. Sometimes we met at alternative places because of pest infestation. So kind of noting, like where they are, and they're being very flexible on where they see patients. So not just in their home or in a clinic setting or in offices. It could be at a restaurant or a community center down the street or just at the bus stop. And then the other quote, but we do it in steps. They're not bombarded all at once with everything. It's like in pieces. So that's really noting and paying attention to the needs of the people that they're working with. And that's why they do have sometimes extended relationships with people, or they have multiple follow-up, like unlike other healthcare providers with patients. And then what we also learned is that the curriculum, like the training curriculums that exist right now, some of the facilitator curriculums don't necessarily fit with how CHWs see patients, as noted by how flexible they are in their services. And we also learned that a majority of their patients do smoke and use tobacco products. And I remember doing this focus group and asking about how many of their patients smoke. It was 6 of them. I was like, "Well, how many of your patients smoke?" And they said all of them. And I was like, okay, well, just give me a percentage, and they were like 99%, like literally every single person that I've seen smokes, So like this is definitely a need here. But they really are responsive to not just whatever the health topic is, but all of their patients' needs. And then one of them shared that they did do one of the official tobacco cessation facilitator programs. And then this is another quote saying that, I received feedback from a person who participated in one of her smoking cessation sessions, and they thought it was really great. They thought it was very inspiring, very encouraging, but they still had all of these surrounding influences and factors that just wouldn't allow them to completely detach from that behavior. And so here in this focus group, we really are learning that there's a need to consider how CHWs, their unique care model, but also how the curriculum is relevant for the patient population that they're seeing that is under-resourced and low-resourced, with low access to services. So we followed up with the needs assessment. So identifying there was a need to do some kind of adaptation, and there was a gap in knowledge. We wanted to, again, not recreate the wheel here, but also be efficient with this process. So instead of taking the needs assessment and designing or adapting a curriculum, we started off by just creating an outline. And so we created an outline of what we would put in a tobacco curriculum, and we based it on and I'll talk about this more at later slides, the WHO toolkit for brief counseling, or for using the 5 A's and 5 R's for primary care, is what we adapted. And so we took that and we created an outline of what we would put, what a training would look like, as far as how long it would be, about like 2 hours, and the format of this training, and then also the content of the training. Then we ran focus groups with community health workers and stakeholders, so community health workers, or health worker managers, and managers of community health worker training programs. So we worked with someone who worked at one of the community colleges that had an associate's program for a community health worker. And then we got feedback from the outline. And then what we learned overall is that, an adapted curriculum was acceptable to them. That's something that they were interested in, and also was appropriate for the clientele that they work with, or the patient population that they work with too. And then the other, the results of the focus group was that, we had 4 main themes. Like after they reviewed the outline, the content, we also developed a sample PowerPoint slide of what a training would look like, that the community health workers reviewed during the focus group and gave feedback on. And so what we learned from that is that, some 4 main themes emerged after doing our qualitative analysis, was that, for their population they work with, smoking is their main coping mechanism and its main stress reliever for the recurrent stressors and traumas that they're experiencing. And then, because of that, they also developed this routine for it. And then they really were interested in really personalizing how smoking is related to the specific health needs of patients, because the majority of their patients had, co-occurring chronic conditions as well, and comorbidities directly related to smoking. And so they thought that it was really important to kind of incorporate that together, and not think about, tobacco as or treating tobacco as separate than all of those other things. And then as far as the biggest take home we got from the focus groups was that that motivation was very important in the teaching the CHWs how to motivate the patients, because many of them, we presented kind of like a 5 A's type curriculum, and things about helping people to quit, and like what to do when somebody's ready to quit. And they were like, that's great, but most all of our people are not in that ready phase. They're like not in a they didn't say like they're basically in a pre-contemplation phase of quitting. They're like not ready to go at all. And so they were like, and then we have many people who know that smoking is bad and they should quit, but it's too much. So therefore they're not prioritizing and not ready. So how do we work on those? What do we say to them, that aren't even thinking about quitting right now? And then following up with that, they really wanted some key language of tell me like what I can actually say to a person. How can I respond to a person? So we really took those last two themes to heart, to think about how to like design and develop our program. And this is a exemplary quote of kind of like, combining exemplary quote of some of the themes that came out. Now I want you to give me some talking points as, okay, the client said no, they're not ready to quit. Okay, and you know they already shared with me that they already know the dangers of smoking. They're just not ready to stop smoking. That's where I want you to give me some talking points. So this is they were highlighting to us is that, you know, calling the quit line, you know, getting patches, all of that. You have to be at a ready state, a different, you know, stage of readiness for that. And they were like, and you know, education is not just sufficient here because people know that smoking is bad, but it's just too much for them. They have too much going on, and it's their main coping mechanism. And many of them highlighted in the focus groups how they felt uncomfortable knowing that cigarettes were their you know, clients' main coping strategies. If we take that away from them, what are we going to give this to them as a replacement? So that was something that was actually a concern for some of the CHWs of like, this is their main way that they know how to cope. Like you literally are taking away their main way that they have to cope with every single like recurrent, you know, stressor that they're having. So what do we do there? So from the focus group, so from the needs assessment information, then from the focus groups, the things that we got from that, then we just started to do an adaptation of a tobacco cessation training for community health workers. And this is what we call the change training. So we developed a 2-hour training, knowing that, you know, 8 hours or 4 hours or, you know, or a full day training was probably too long. And then considering how the CHWs see patients, they really are these connectors and these like support workforce. So they're not necessarily, all of them won't get to train as tobacco cessation, you know, or tobacco control specialists, but they still need some information. So we start with the WHO toolkit for delivering the 5 A's and 5 R's brief tobacco intervention. So we just kind of went down. We included each of the components of the toolkit, but then we adapted it for on 2 things: the CHW model of care, and then to be relevant for an underserved, like low resource population. And so, like, for instance, here are some examples of how we adapted it. For background tobacco use, we learned that we emphasized the tobacco industry's targeting of minoritized communities, because that was something very powerful as we're going through focus groups that the CHWs like noted as it's just something they just didn't know, and as part of a motivation that might be motivation for, you know, people to help them think about quitting smoking. And then we highlight the unique role of the community health workers in tobacco cessation and their flexible delivery model and kind of their continuous interactions with patients and their trusted relationship. We emphasized tobacco use in relationship to other chronic conditions. I'll talk about this on another slide. We've also focused on menthol use and co-use with marijuana. The benefits of quitting, we still included that information, but as a handout to use if they needed to, or to hand out to their patients. And then one of the key things that we developed case examples to kind of walk through the information on presenting the background information to put everything in context with the people that they're working with. And we focus a lot on stress and mental health here. And for the 5 A's, we still presented the 5 A's, but not in the packaged way. So we talked about, like, you know, asking and advising, but we really focused on assessing, and we kind of expanded that and really ended our program on a motivational interviewing and focusing on motivational interviewing for smoking cessation. And create a handbook of actual responses they could say to patients. And then we discussed, you know, many of the CHWs have had training in motivational interviewing in general, but we discussed it in the context of smoking cessation. And then we did role playing at the end, because they really did talk about like wanting to practice skills and develop skills. So the last part of our training is about them actually role playing and using those case examples to have conversations about tobacco and using a motivational interviewing framework. This is an example to kind of go through some of the slides. So we incorporated role playing by using real life examples. So we introduced 2 case studies, Mary and Sean, that, you know, you could see throughout the program or throughout the training, and kind of putting into context, like Mary, who's a 63-year-old woman who's been smoking for 40 years, but also has COPD and supportive oxygen. We kind of, you know, Mary was kind of like seen throughout of kind of tying it back to Mary and tying it back to people that they might be seeing in the community. And then we also had an example of Sean, a 20-year-old who said that he could quit whenever he wanted, but he also lived with his mom and his aunt who also smoked. So we commented on the intergenerational smoking and things like that. And then we have, Brenda, who, has diabetes and, also lives with someone who smokes in the house and things like that. So we incorporate these cases throughout, and then ended with doing role playing. And then what we learned is that we started off, it kind of like, this presentation here, I started off with like my slide about like tobacco use. And we had graphs about the rates of tobacco and the rates in these communities. And in our focus group, we learned that like they were just like, we don't need all that. We can look that up, like just kind of get to the point of like what we don't know. And so we deleted content on like some of that background information, like the graphs, and then we just provided examples that are relevant to their clients. And so one of that is about the tobacco industries and about the targeting of certain minoritized groups. And then also we talked a lot about tobacco use and marijuana, because many people that they're working with are using both substances either together or in tandem. So we kind of just put marijuana in the context of tobacco use. And then we created a handbook and handouts. We created a handbook for them that consists of handouts they can actually give to people or like use for themselves, to talk about how tobacco is related to other chronic conditions like diabetes and heart disease. And we had 10 of them total. So like, cancer, HIV, tobacco and weight, secondhand smoke, COVID-19, pregnancy. So we kind of went down the line there. And for them, of like kind of simplified key takeaway material that if they wanted to say something about it and educate someone about it, they had that there for them. And then lastly, what I'm most proud of is that we worked on creating this motivational interviewing handbook where it's actually quotes and things that they can say. And so we practiced motivational interviewing. We went over like a review of the general context of it, and then we talked about it in the context of smoking cessation, like in the presentation. And then at the end they practiced, but they had some like a where to start from here. So like and we grouped together in themes of like what you would hear a client or patient say, because some of these things it's different phrasing, but it's kind of the same underlying message of either not thinking about quitting, I can quit whatever I want, or like I'm just too tired, I've tried before, or like I'm too old now, I'm already sick, what's the point in quitting? Or just like some like fear around like, well, I don't want to use NRT because I heard that it gives you heart attacks. So like we created like kind of themes of it, and it had some common like MI responses you could say. And then we have maybe about like 14 pages of like actual specific quotes that looks like this on this right side of an MI response of what they could say, and then phrases to avoid, importantly, of what we might want to say or naturally say, but how that will close off a conversation. And so we actually have them practicing doing the MI response and noting like, when they, started to say those phrases to avoid, like how to move on from that. And then, so for pilot tests and so forth, so we've run the training since I've done these slides. We had run the training, we had like 3 trainings. So far, I've done 3 more of them. So we are collecting more pilot data, which is exciting. But we recruited 3 local community-based organizations and a CHW degree program at a community college to attend this training in person. And then we collected pre and post questionnaires to see if there were changes, what effectiveness the training had on their knowledge, and then also their confidence, readiness, motivation for providing tobacco cessation treatment, also their confidence in using MI for tobacco cessation. And then so overall, like from pre to post, there were positive effects on all outcomes. So there was a significant increase in all of those items, the readiness and also the knowledge, which is great. And then we just started to collect some follow-up data. And so we have only about like maybe 15 people so far on 1 month. We ran some trainings a year ago. So we have 6-month data for a few, and then we have one month data from a few from trainings that happened earlier this fall. But interestingly, we saw this increase in knowledge pre-post, which was great. At 1 month follow-up, you see that the average out of 10 was about 6. for the mean score on the knowledge. And that still was not different, significantly different from that was still significantly higher from the baseline knowledge. But at 6 months, you see the knowledge start to drop, and it wasn't significantly different from the baseline knowledge too. And so that's interesting to me, kind of this knowledge trajectory over time, and kind of that, lends the question of, is a 2-hour one-time training sufficient? Is that sufficient for them actually utilizing these services? Is it sufficient for them gaining and maintaining knowledge? And so my next step I really want is to think about how to optimize this program. So whether it's a one-time training versus this training plus some kind of booster session, or whether that should be an actual booster section of content versus just kind of like a learning collaborative where CHWs can come and just kind of like brainstorm like what worked and what didn't work. And so that's like my next step in this process to look at how to optimize this program, and then also look to see the effectiveness of this on actual patient outcome and utilization of services. But so this is my nice, I call this the colorful circle. But we're taking an EPIS like framework to adapt this program. So our exploration phase was the needs assessment, selecting the WHO toolkit and doing those focus groups on the outline. We did a preparation phase. We actually worked with a community health organization called Crowd, who actually is a CHW training organization. They actually, consult on the CHW model and different healthcare systems. So we actually partnered with them to review our curriculum and the PowerPoint and the materials before we ran the pilot. And then the biggest part of our preparation phase is that we focus on motivational interviewing as opposed to like focusing on like a 5 A's model. And we identified that was like the focus for community health workers. And then we did the pilot trainings now. So this is kind of where I am in the model. And then my sustainment phase is like the next step is I really want to think about how to sustain this, right? I mean, a lot of this work has been, grant funded. I'm actually contracted by the Chicago Department of Public Health right now to train their response corps, who are the CHWs that were actually hired under the COVID-19 contact tracing, and they were retained under the Chronic Disease Prevention Center. And then they and so now they're doing these, their priority is tobacco, which is great. And so, but we did like a tobacco 101 session for them. They're like, okay, well, I think we need more. So we did this. And that they have like a 6-month program or something like that. But anyway, all of it is like grant funded. They get money from the CDC and other things. And so, the question is like, how do you, especially with this variable workforce, sustain a program like this? And so my next step, my parallel next step is to I'm working with someone at the University of Arizona actually to do a train the trainer model, so that I can, once people go through this program, they can do like a separate, like how to teach this program things so that we can embed this within organizations, or I don't know. So we have to think about that, as always. But anyway, so this is my wonderful lab who helped me work on this project. It was an amazing team. And here are some of the community health worker organizations that worked with us during this project, and the community health workers who definitely like spent their time to help with like the needs assessment and other things in this project too. But that's it. Oh, yay, we have like 20 minutes for questions.
Wonderful. Marcia, thank you so much for this fantastic presentation. I'm already starting to see questions come into the chat. I am going to invite Catherine Demko to come off of mute if she'd like to ask her question in person. I'm glad to see you here, Catherine.
Well, good afternoon. That was a wonderful presentation. I deeply appreciate it, and I had a little bit of experience in developing a curriculum, tobacco cessation for dentists. Oh. And we did it online. And then the pandemic hit, which actually would have seemed to have worked well because it was supposed to be online anyway. But yes. The problem was dental offices closed down, so they didn't get a chance to use it. But I will say one thing before my question. Honestly, the bang for the buck was in MI. And what the dentists really, really appreciated was several tables of just what you did. The examples of what does a patient say and what should you say to be, am I consistent? What should you not say so that you are not, am I inconsistent? And that's how we phrased it to them. My question to you was, in your follow-up, did you happen to ask how often they tried to use their new skills? And did that show any correlation with their knowledge sustainability? And again,
Yes.
thank you for the very excellent presentation.
Of course, thank you for that question. Yeah, I haven't gotten into the follow-up data yet. I just did a cursory, look at the knowledge for this month. But we did, yes, we did ask how often. We asked what, like which parts of the program that they used. So we can have the count of if they were using, the comorbidities handouts or whatever. And then they said we also have an online so everything we have printed out, we have online on our website. And I said that so far what I've looked at is most people have used the online resources or like reference the online resources so far. And also the tips to quit handout, I think was the one that it was one of the handouts we have for the patients they use the most. But I haven't looked at that, but that's my next step is I do want to see if the knowledge is correlating to their utilization of it. But we did ask that question of how often. I just haven't looked at it yet.
I'd invite others to come off of mute and ask your questions if you have any for our fantastic speaker. I have a long list and I don't want to hog the time, so. Well, I'll start off with one. I appreciate the last figure that really showed the thoughtfulness of the development and then your move towards sustainability. I wonder if you're thinking also about scalability or transportability, right? And extending this work from where you are to other spaces where community health workers are really taking on those same kind of tasks in other geographies.
Oh
How
yeah,
would you do that and thinking about that?
I definitely am. I think that, because this project happened during, our COVID years too, I've always, we've designed this to be in person because we do think the in person is, it's like, impactful to be there in person, and we give them food and like all the things, but we still are going to design a online version or a Zoom version of this. We still are thinking about doing this synchronously. And I think that's why I do want to move towards the train the trainer type model, knowing that if you are going to be in an organization or in one space with someone, there is someone who can do that training. I think just the asynchronously is it's not going to be, I think, as impactful, especially because you're trying to practice the skills. But we are going to probably pilot a Zoom, just doing this through Zoom, because we can still do like breakout, because they basically get into groups of 3 at the end to like practice, and they practice role play, being the CHW, being a patient, and then an observer, and then they switch for like the 3 cases. And so you can still, do breakout rooms for that, right? So it's still possible. So we still want to pilot just to make sure that's a possibility to do. And we had to do that too. We had to turn our in-person focus groups to online in the middle of COVID, and that still worked out fine. And that was great, So that's what I'm thinking about. But yeah, and when I say scalability, I do want this to be something that is not just here, in Chicago. And I'm working with someone from the University of Arizona right now that actually met at SRNT this past, March, to think about, developing that, because the idea is that I will, and so that therefore, so to answer your question, thinking about that, I probably will have to have some kind of Zoom or virtual option if I am going to be training people in different states, or there's training in different states or something like that. But the idea is that it can be distributed and then trained within each region without having to physically be in the same place. So that's kind of how I'm thinking about that.
Well, Cleveland has community health workers. So.
Yeah, I know.
Anyone else? I see some other folks have come onto camera. Any other questions? Go ahead, Jim. Yeah.
Thank you, Marcia. That, hearing you talk about this is always really energizing for me. And I'm always just amazed by all the resources that you've put together too and have on your website and all of that. And I know in our conversations, you've often positioned this as like workforce development, which I think is super cool. But my question to you is sort of, what are these, I guess maybe it might be the next step or the next step, a little bit around like, how do you see this work then, like, how do you think you'll measure kind of reduction in tobacco use disparities and kind of at the more client level or patient level, person level, that sort of kind of plans, if any?
Excellent question. Yes. And I do want to move. I mean, I do think that optimization of the training in the workforce is valuable in itself, but like, yes, I do want to see the next steps. So what I've been proposing and thinking about is it's hard. I think that the hardest part is if I'm trying to maintain the CHW model of like the flexibility and how they see care, then that does not lend itself to like a controlled, trial and things like that. So like thinking about a pragmatic way to do that. What I proposed is as a starting point. So basically the question is, okay, if I'm going to train CHWs and then I'm going to measure their adoption of this. So I don't want to train them, measure their adoption. It has to come from them. I think that's like the only pragmatic way to do it is for them to like, self-report. I mean, I could design something to have like, to watch them have conversations, but like just to kind of, they have to self-report what they do. But then I think that there has to be a level of like recruitment into a study of who they see, right? To see what the effects are. And that is the hardest part that I'm trying to deal with. What I proposed in a grant that I have under review right now is to kind of, because things really concentrate in Chicago, specifically at the neighborhood level. And so many of these CBOs are embedded within specific neighborhoods, and it really isn't, people really are just serving that particular area. So like the fortunate thing for my research about Chicago neighborhoods is very segregated in like the neighborhoods. And so these CBOs really do kind of pop up and exist to serve like just one specific community. So I'm kind of looking at things at the neighborhood level change of pre-post. So basically pre-neighborhood level, and we have like Chicago Atlas data to give smoking rates like at the neighborhood level, which is nice. And then like pre-post of like train the CHWs, like in that neighborhood, and kind of looking at like overtime pre-post of like the rates like at an aggregate level. But yeah, so that's the question of the of the century, Jen. But I do want to, and I'm trying to figure out if I can do this in the most pragmatic way. But I think, if it comes down to, I'm going to have to do some more of a controlled trial of recruiting people into a study and following them, and then training them and then pairing the CHW with the person to see how their, rates change, then I will do that. But right now I'm trying to do this as pragmatic as possible. Yeah.
Thank you for that answer. I think this is a really challenging thing to sort of get to, right? Because I feel like for the folks who are still smoking, there's not a single silver bullet, right? And that's what trials typically do, is assume that your intervention is the silver bullet, and that perhaps it's additive or a step right on the pathway, that there are these other intermediate outcomes that might be just as important as moving people along to cessation. And we don't always know how to give ourselves credit for that. And so thanks for sharing those perspectives. Rebecca, do you want to come off mute and ask your question?
Sure. Thank you so much, Dr. Tan, for your presentation. Better now?
Yes.
Okay.
Great. Thank you. Thank you so much, Dr. Tan, for your presentation. It was amazing just hearing about all of your work and inspiring as well. So I was curious, you mentioned folks had heard certain symptoms were related with smoking cessation treatments and medications. So I'm curious, if you've noted any patterns of successful quit attempts among participants, and if you've seen any patterns like that may be more successful as compared to others. And then related to that, I'm curious, if you noted any trusted sources that are common among community members as to where they get their health-related information, especially around the medications and the treatments and the symptoms.
Mhm. That last question is a really good one that actually I want to, so we've been surveying the community health workers themselves so far, not necessarily the people who are smoking, but I am learning that some of the community health workers who I've been working with are smoking themselves too. But I do want to include in the information of where their clients or patients might get their information. But the trusted sources I'm learning, it really is like friends, family, community. It's not doctors or physicians or anything like that. And I think, and I don't know to what extent that is through like social media versus word of mouth and things like that. But as far as your other question, I'm reading what you wrote here. I don't know that information yet. And I think that we do talk a lot in my program about, affirming, people's like efforts, affirming like what they've done. And so like we do like try to train them on getting the information on how they have made efforts towards quitting. And what I call it is like the journey to quit smoking. So the idea that it's like a journey. It's not just like you made an effort, you're done, kind of thing. And so we do train the community health workers to talk about, how they've attempted in the past. But as far as the people that we're trying to like serve through training the community health workers, I don't have that information, but that's good. That's a good question. But, and that's the thing is like, we like for, I think for the CHWs themselves, many of them have said that they are like, they say that it's a range of how their clients view them. So some of them will report that they view them like, a cousin or like an auntie. Some of them will report they'll call them, "Hey, what's up, doc?" when they see them because they're coming in talking about health stuff. And so, but I still think that they uniquely have a trusted relationship with them, regardless of how they're seeing them. And so that's what we're trying to like, capitalize on that, relationship of like how they're communicating with the people. But yeah, the trusted sources are mainly community, family, friends, and things like that. And that's where people hear of things, right? Anything else? Yeah, I was like, I think I just talked around your question.
No, I really appreciate it. And thank you so much for your answer. And I was just curious, especially with the attempts, specifically because of the guide that you created around motivational interviewing. I feel like it would be really interesting to see, what patterns develop based on how folks have tried to quit in the past and how that helps people get motivated again to try it a new time, right?
Yeah, and that's what I want to measure for like the grant that I have under review. My outcomes are the attempts to quit. Like they're not necessarily like yes, I will be measuring if people are abstinent, but my main outcome is their attempts and like how that changes as a result of interacting with the CHW. So I'm going to try to do it on the back end of looking, on the statistical end of looking to see if like number of CHW interactions is related to attempts. And I'm proposing like a ecological momentary assessment. It's a really cool project if anybody wants to fund me. Okay. but I'm proposing EMA to track changes in social determinants of health and their quit attempts, and then the number of contacts they have with CHWs, to kind of get a sense of like if the CHW interaction. And also, I think that the biggest limitation is that interaction could just be the interaction itself, not necessarily the fact that they're trained, but I want to compare it to who is trained, CHWs trained on the program and not, to see potentially get at if it's a trained CHW on this program that influences the quit attempts. But
great question. I have another question that's a bit adjacent, but comes up for us a bit that we try to figure out. And that's how pharmacotherapy sort of fits into this. And, I think there are some myths and concerns around the use of pharmacotherapy, but at least in the literature, we know that it improves the successful quit. So I'm wondering how that's sort of fitting into these discussions, as well as access issues that might come up, particularly for the populations that are most served by community health workers.
Yeah, so we have a whole like a whole slot that goes over NRT and medications and counseling and kind of like the main treatments for it. And then in our binder, do I have one? I'm gonna pull up a binder real quick. This is our handbook, just by the way, let me take off blur. And so we have this whole section on nicotine replacement therapy for them that goes through like, here's the patch, and this is what a CHW needs to know, and this is how to use it and all that stuff, and here's where to get it. And then we go over in our presentation, like where to get NRT in Illinois,
Okay.
so they can
Yeah.
know that like, because I can call the quit line, you can get this, Medicare covers this in this way, Medicaid covers this in this way, and stuff like that. So we really spend a lot of time talking about that and like dispelling myths and all of that so they can know for sure. And then knowing that it is accessible. So for the CHWs to know that like under the ACA, it should be covered like regardless, but you might have to do extra things like call this number and do that stuff for your patient or help your patient do that. So yeah.
Awesome. Awesome. Thank you.
Mm.
Any other questions from our friends in Zoom, from our audience? Well, then I will take this moment to say thank you again, Dr. Tan, for your fantastic presentation. We may or may not have shared with you that we have a significantly high rate of smoking here in the city of Cleveland. And so it is always on our minds how we can do more to serve our community and find innovative approaches like yours to work into the cadre of resources that we have available. So thank you for sharing your knowledge. Thank you to all of those of you who've joined us today. We hope you'll join us again in January for our next seminar. If you are excited to share this seminar with colleagues, please check back on our YouTube channel in a couple of days, and we'll have that up for you where you can share that link to Dr. Tan's fantastic presentation. And thanks again. Have a great
Thanks
afternoon,
for
everyone.
having me. All right, bye.